Welcome back to the Pulse Check Podcast. Today we are having a conversation that every woman and honestly every person who loves a woman needs to hear. We're joined by Aimee Hopkin, a psychiatric mental health nurse practitioner with over 13 years of nursing experience and 2 years as an NP. Aimee has an incredible background in women's health, spending much of her career in labor and delivery, working in home health and hospice, and serving as a lead research nurse in women's and newborn research. Today, we're diving into a topic that impacts every woman but is still surrounded by so much confusion: menopause. We'll talk about the science behind the hormonal changes, how they affect the brain, mental health, sleep, metabolism, and overall health, while also discussing how women can better understand and advocate for themselves. Aimee, welcome to the Pulse Check Podcast. Alrighty, girl. So, you've worked in labor and delivery, hospice, research, and now psychiatry. I want you to walk us through that whole journey.
Okay, so I started out in labor and delivery. And that is why I went into nursing. I wanted to work in women's health. So it was really the only job I ever wanted.
Okay.
I had done like a clinical shift on mom baby, and bless her hearts, I couldn't. No, it was just.
What did you not like about it?
It was a hamster wheel. I just felt like I was, crede, ibuprofen, next one, crede, ibuprofen, the next one, crede, and it was just boring. Which
shout out to you nurses out there.
No, and I respect
You're so great.
them because they catch a lot of, but it just is like for my brain that was not going to work. But I only ever wanted to work in women's health, and so I started out in labor and delivery. I felt so lucky. I loved that job. I ended up doing home health and hospice sort of accidentally because my sister worked there in HR, and then my other sister worked there as their bereavement coordinator. And they're like, we just need someone that can fill in the gaps. And so I worked that job for a while, but it was sort of a PRN kind of thing. And I really love that people don't realize there's a lot of overlap between hospice and labor and delivery, like those big transitions.
Yes.
And so it was actually really rewarding to be a part of that. And then, so that was going on while I was in labor and delivery. And then when I went back to school to get my degree for psychiatry, shift work wasn't really conducive to that. And my husband passed away at that same time in 2020, and shift work was not great for someone who still has kids at home and doesn't have a partner. You could go spend Christmas with your dad.
Yes.
And so research was 9 to 5, but it was still on my floor.
Okay.
I was still in labor and delivery, so I was still with my people. And I really liked that. It was very exciting to do some like new stuff, and it was really interesting. We did a lot of really cool studies, but I did that while I was finishing up school, and then I transitioned into this, and and I ended psychiatry.
What made you go into psychiatry in the first place? Because that's a huge jump.
Well, yes and no. So first, there's a lot of psychiatry that happens on the floor.
True.
Right? But you're in a room, and it was interesting when I was on labor and delivery, I ended up with a lot of the like demise patients, because we also had a lot of like young moms that worked the floor, and we just didn't feel like it was great for them to be in a room with someone who was the same age as them, and dealing with loss.
That's really nice of you guys. Very thoughtful.
But I really loved doing it because it felt like I was providing a service that went beyond just labor and delivery. So like that, it was already there. This is maybe more than you more want to know.
I want to know everything. Yep.
So how I ended up in psychiatry specifically was, so my husband dying was a real pivot point for me, right? And we'll go into some psychiatry or some psychology.
Yes.
There's a thing called ambiguous grief. And ambiguous grief is mourning what you thought should have been, right? So when somebody dies, you mourn the fact that that person's not there anymore, but this ambiguous grief comes in, and it's, I had the next 50 years of my life planned out, right? I
Yeah.
knew exactly what was going to happen. You know, Ben was going to do this. I was going to do this. We're going to retire and, you know, visit our grandkids. And when he died, that future wasn't available anymore, right? And I grieved that. But then I was like, I've got to figure out what I can do that's going to give me meaning in my life, but also still be in this field of nursing. And so, and also the more selfish part of that was we were a dual income family. And I was like, I'm not willing to go back to a single income type of thing. And nursing, bless its heart, doesn't make you rich.
No, it doesn't. Even though everyone thinks so.
Yeah,
a lot of people, when they hear, oh, you're a nurse, you must be making a lot of money. No. Especially not in Utah.
No.
Okay, absolutely not.
No, we're like one of the lowest paid.
Yes.
But most people don't go into nursing for the money. They go into it because it's something that they are passionate about. But that was a factor. So I don't want to just go into a clinic job and work a 9 to 5. I needed to do something that was going to provide a little bit better. And so I was reading a book, and it's called Kayak Morning. And it's a memoir of a man who lost a daughter to cancer, an adult daughter. And he's out he lives up in like Cape Cod, so he's out kayaking in the bay every morning, and he's writing down some of the thoughts that he's having, and he's recounting this experience he had with this therapist, and he was talking about his grief, and he says to her, like, I don't like this. I don't like grief. And she said, well, essentially, that's too bad, because grief is a part of your life from here on out. And he goes, well, what am I supposed to do with that? And she says, you need to think of the person who sent it to you. And like, there was nothing in there specific, but it was, for me, it was almost like this like thunderclap of, oh, this is what you're gonna do. You are gonna walk other women through the hard times of their life.
That almost makes me emotional. Right? I'm gonna start crying.
So it was actually kind of funny, because then I went through, I'm like, oh, I guess I'm gonna be a therapist. And so I was online trying to figure out, well, how do I
I know, we're grabbing the tissues.
How do I do this? And what education am I gonna need? How do I transition my nursing into therapy? And when I'm Googling it, psychiatric nurse practitioner pops up, and I didn't even know it existed. And I was like, okay.
There it is.
And I knew I wanted to continue working with women. So that's where my focus became, is how does psychiatry interact with women's health, and trying to figure out all sort of the nuances of how to treat women in psychiatry. It's been cool.
Right. Well, obviously it's been awesome, Holy, because I remember even when me and you first met, I opened up to you about my uncle who had lung cancer. And I was like, during this time, like, how can I best support my aunt during obviously one of the hardest times in her life? And you just like spilled it all out to me, and I was like, I didn't even know your husband died. And Aimee, you have the worst ways of bringing up your husband died. Like, guys, we'll literally be in a conversation with a random person, and she'll be like, oh, my husband, who's dead now, by the way. And then she'll like just continue on, and I'll be like, Aimee, you can't keep doing that. You just made it so awkward.
Well, it's also like the best, like, so I was at a white elephant gift exchange party, right? And I unwrapped this thing that I really, really liked, and someone tried to steal it from me, and I just look them dead in the eye and be like, I'm a widow. Are you going to steal it from a widow? And of course they're like, no, no. And I'm like, yeah,
put their hands
that's
up.
what I thought.
Whenever I see something to my aunt now too, she's like, Sammy, my husband's dead. And I'm like, you can't say that. You can't be doing that to me. That's terrible.
Well, no, because you have to find that in it, because
you have to have humor in it.
Too heavy if you don't.
Yes.
My husband was cremated, and my kids and I send like cremation jokes to each other. All like there's a whole thread of Instagram stuff where it's like urn jokes.
Right.
Earn, URN, not yeah.
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 You're earning this.
But anyway.
That is so crazy. Okay. Well, they probably think that we're just talking about grief today, but we're not. We're not. But okay, so with what you do today, what do you love most about it?
I love when women come in and they're desperate. They don't they've been either dismissed or ignored or told something is normal or whatever, and they're just so distressed. And then to be able to talk with them and take the time that they need to really go into like detail about what they're experiencing, and then coming up with a plan and having them come back and go, I'm happy again.
Oh.
Like, I'm enjoying my children. My brain's quiet. I slept through the night for the first time in years, right? And to see that happen and know that I was a part of it is just really rewarding.
Yeah, how does that like make you feel, I guess, in your insides?
Just real happy.
Yeah, you're just like,
real happy. Yeah, because I've been there, right? I know what it feels like to just feel like you're being swallowed in either grief or anxiety or depression, and just wanting a lifeline and not being able to find the lifeline. And then someone reaching out and saying, yeah, no, here's what we can do, and we'll walk through this together until we figure out what's going to make you happy and what's going to make you feel like yourself again. And it's been great.
Good. I do feel like when people go into psych as a career, they have a personal experience with it. Generally. Like, they've struggled or they've known someone else that has struggled super bad. Like, it's always a very personal experience. So, that's great to know yours. Okay, so you have a lot of women walking into your office today. I feel like a lot of the time, a lot of them can be seeking like a diagnosis or a medication to automatically help them feel better. But usually they're seeking something deeper than that. What do you think that is?
I think they want someone to just validate them and understand, to tell them they're not crazy, that this isn't normal, that this isn't something that they're just going to have to live with, right? It's just, I want someone to listen to me. Yeah. I want to feel like I'm being understood and to feel like I'm not alone.
Right. And just heard.
Just heard.
Like, just listen to me here. Yeah. I can see where that would come from. Yeah. Okay, so August is coming up. You're planning your Menofest. Correct. Let's talk a little bit about that. Kind of tell the audience what that is.
Okay. Menofest is the menopause festival.
I'm so excited.
So a little less than a year ago, I was at a conference that my sister was presenting at. So my sister's a therapist, and it was geared towards moms, young moms mostly. And I was there. Definitely that's not where I am right now, but I was there to support her. And there was so much good information, and it was a fun event. But I remember going, this is so not relevant to me. And I really wish that there was something like this that was discussing this phase of life. Yeah. So I got on my phone really fast and I Googled it, and there wasn't anything. And I leaned over to my sister, who was with me, who's also in that same age as me. And I said, I'm going to do this, but for our age. And she goes, yeah, you are. And
so supportive.
Yeah. And really what it was is I have a lot of women come in, and especially around menopause, that there's a lot of conflicting information. There's a lot of snake oil out there. There's a lot of old research that's being brought up, and we have a lot of providers who aren't trained in menopause because we had this horrible study come out 25 years ago that said, yeah, you can take hormones, but it's probably going to kill you, so only do it if you're desperate. Oh my gosh. And so you have a whole generation of prescribers that don't even know how to prescribe hormone replacement. And then you get women going in, and they're meeting with a doctor who has this old information, And so we wanted a day that women could come and understand what's happening with their biology. Because we're not told. We have no idea.
Why do you think that is? Like, why do you think nobody talks about that?
Because we're a puritanical culture that doesn't like to talk about bodies and sex and things, and women's health has been largely ignored since medicine began. And so it's not prioritized. So I think that there's a lot of reasons, but I think the biggest two are we don't have a lot of women's health research, and two, the study that came out that just, so nobody, the information just stopped, right? So, and the biology too. Like we get squeamish around women's bodies. Like it's really interesting if you go to my friend, her daughter just had her maturation program. And the information that came back was just so limited. It was like a picture of the ovaries, and that was it, right? Like,
what the heck?
Yeah. And so there wasn't a whole lot of discussion about their biology, and it was like, oh, you're going to have a period, you're going to bleed once a month, and just get used to it. And that was kind of it. And so we just don't.
Yeah.
Yeah.
That's so weird.
But, so I want women to understand their biology, what's happening in their body, what options they have as far as treatment, so what's safe for them, what's not, what's available, and then also to have the language to be able to go to their provider, and when they're dismissed or they're told it's normal or they're told it's just part of aging, or they're given outdated treatments, that they have the ability to be like, nah, and advocate for themselves.
Right.
But we also wanted to do it in a way that was fun, because midlife isn't when your life ends, even though that's sort of the message that we've been given, especially women.
Right.
Like when your reproductive age ends, so does your usefulness, so does your worth, so does everything else about you. And I can tell you I've never felt more in my skin than I do right now.
Oh, that's amazing.
Absolutely. I mean, are there downsides to this age? Yeah. Like I tell people I'm at the age where I make noise when I stand up, whether it's like my knees or me going, right?
I do that at like 22.
But it's also, I'm in the thick of my career, and I've got great relationships, and my kids they're grown, so they don't have the demands that I had as a mom, and I'm not worried about whether people think of me anymore.
Oh, that's such a good feeling.
I'm like, this isn't something that we need to mourn. This is just, hey, let's celebrate the fact that we've reached this age, and let's give everyone tools that will help them age with vitality. Yeah. So it's, we talk about hormone replacement, but we also are going to talk about like libido and sex as you age.
Thank goodness.
Regulating your nervous system, and what you should be eating, and how you should be, what exercises you should be doing, so that we don't have to age like our moms did. Right.
Because they didn't have the education that we do now, right? Do you feel like when it comes to HRT, hormone replacement therapy, a lot of I guess providers kind of hold off from prescribing that because of the lack of knowledge or like education?
Yes.
Why do you think they're having such a lack of education?
Because again, women's health is not prioritized. Yeah. And to this study, so it was the Women's Health Initiative. It came out in 2002, and it was this huge study that looked at hormone replacement therapy and whether or not it was safe. And the conclusion that they came to was that you were at a much higher risk for breast cancer specifically, but other diseases too, if you did hormone replacement. Okay. And that was just sort of the prevailing wisdom. Everyone just sort of took that as gospel, and so the average OB-GYN gets about 3 to 7 hours of instruction on menopause in medical school.
That's it.
That's it.
Oh my gosh.
Yeah. For something that happens to 50% of the population.
Yeah.
And happens to every single woman. Pregnancy does not. Right? PMS does not. All these things do. Menopause will happen to 100% of women if they are lucky enough to reach the age of 50. Period. You cannot get around it. You cannot stall it. You're going to go through menopause.
Right.
But there's just, I guess they thought that there was nothing they could do, so why even teach it, maybe? I don't know. I'm giving them the benefit of the doubt.
Yeah.
They're not just like women.
I'm going to tell my brother that's in medical school right now to make sure he's really studying hard for this stuff.
Right? So, and so this thing came out, and everyone stopped learning about it. Mm-hmm. And then a couple years ago, when they came out and said, this was a deeply flawed study. They were including women that were past the age of menopause. So there is definitely is a window. But they were including women that were postmenopausal, that were in their 60s, 70s, 80s, and your risk for things like breast cancer go up with age, period. Doesn't matter what you're taking.
Yeah.
But there was a whole lot of stuff that was flawed in this, and now that we're re-examining that study, we're going, oh, wait, no, you're not going to get a blood clot, you're not going to get breast cancer, you're not going to do all these things. It's very safe. But if you are a provider right now, it is on you to go out and get that information.
Right.
Nobody's bringing it to you. Nobody's teaching. So,
educate yourself.
You have to educate yourself. Mm-hmm. And usually at a pretty good cost too, right? Yeah. So this April, for example, I went out and did they call it like a mini fellowship or intensive at Harvard.
Wait, was I with you when you were doing this?
No,
No, okay,
because this was in April, and it was was in Boston. It was with Harvard Medical School, and it was this week-long, 8 hours a day, 5 days, plus another 40 hours of video instruction on just this topic. And
so you got more than doctors do.
I got more than doctors do.
Wow.
Right? And if you want to understand hormone replacement, you're out doing stuff like that. Mm-hmm. And not a lot of providers are willing to do that. And so they're still kind of going off whatever information is still circulating, and often that's very outdated.
Right. And I feel like, especially when you're a provider and you're in such a space where people respect your knowledge,
right,
you would think that you would want to get as much education as you possibly can, especially in those areas that people are seeking help in.
Right.
Okay, so since we're throwing out the word menopause, can you just go ahead and explain perimenopause, menopause, postmenopause in a way that someone with zero medical history could understand?
Yes. So the term perimenopause means just around. So this is the period of time before you are postmenopausal. And it's this zone of chaos. It's where your ovaries are kind of working, but not as efficiently or as well as they have been when you're in your reproductive stage. So what's happening is you're born with a certain amount of eggs, and those follicles are what stimulate your production of your sex hormones, so your progesterone, your estrogen. And your ovaries are really good at monthly just saying, yep, pop one out, and then here's your hormones. And as those eggs diminish, that changes, and so all of a sudden you're not getting this steady fluctuation of estrogen. You're not getting that steady influx of progesterone. And then there'll be some days where you have a ton, and some days when you have none, and some days when you have a middle, and then you go back to none, and then you go back to some, and then you go back to a lot, and then you go back to none. And
already doesn't sound like fun.
Right? And so these big shifts are what cause those symptoms. The hot flashes, the weight gain, the brain fog, the joint pain, all of it. And that can happen up to about 10 years before menopause. Menopause is 1 day. It is the marker of I have not had a period for 12 months. And that is the only standard, right? And it's arbitrary. There's no real science behind why they decided this was what marks menopause. But 1 year without a period is what menopause is. And then from there on out, you're postmenopausal. And that is just a time when your ovaries have said, yep, we're done. We have got no more follicles left. Everything's shut down. Factories closed. And that's when you hit this dip of we're not producing our hormones anymore.
Interesting. So when people come in and talk about menopause with you, or when you talk about it, is there a common misconception that you hear?
One, your labs will tell you if you're in menopause or not, or in perimenopause.
Okay.
And this is a really hard one for people to accept, is that we don't have a definitive way of telling you you're in perimenopause.
Okay.
Because lab tests only take a snapshot of what your estrogen is doing or your progesterone is doing on that day.
Mm-hmm.
And when you are in perimenopause, as we, like we were talking about, your estrogen, your ovaries are like, they're going nuts. So we can't get a real idea of what your estrogen and progesterone are doing during that period of time, because I can take your blood on this day and it'll tell me what your ovaries are doing today.
Yeah.
But that's going to be different a week from now, and 3 days from there, and a week from then. And when it should be exactly the same, so if we did it 4 weeks after we did this one, those should look the same, and they're not going to, because you're not producing that nice little curve of estrogen anymore.
Right.
And so maybe if we took your blood every few days for the period of like 3 months, we could get an overall picture of what your hormones are doing.
Yeah.
But one blood test is not going to tell you.
Right.
And so people are like, well, you give me my, like, what labs should you run?
Mm-hmm.
I can't.
Yeah.
I mean, I can if you want me to, and I can tell you what your estrogen looks like that day, but it is not going to be what your estrogen is. And so that gets really, like, frustrating for people, because we're used to having medical stuff where we can definitively say, oh, yes, this lab confirms, or this symptom confirms.
Like a clear answer.
These are clear answers, and we can't do that. Not yet, at least.
Right. Is there... I can't remember. Isn't there like a 21-day progesterone or something that you can order? What is that?
So... there are, when you're in your window of fertility, right, your hormones should look certain ways at certain days of your cycle. So day 1 or day 0 is the first day of your period.
Right.
And then your estrogen has this nice little curve up. It peaks at ovulation, comes down, then there's another little bump, and then it goes back down to 0. And we do this cycle every month for year after year after year. And when we're in that window, we can go, all right, we're going to take your estrogen on day 3, and it should be around this. And we can take your progesterone on day 21, and it should look like this, because that's what's typical. And when you're off, then that signals that there's something off with the cycle. So if your period is fairly regular still, and we know, yep, this is definitely around day 3, and we know this is definitely around day 21. We can do labs and kind of compare that to what's, quote unquote, normal. But again, when your hormones are in such fluctuation, that day 21, if your period isn't regular anymore, so if it's coming every 3 weeks, and then it's coming every 6, and then it's back to 3, and then you don't go, then you skip a period for 2 months, and then you're back and you're normal. That's a good indication that your ovaries are in chaos, and it doesn't really matter that day 21 anymore.
Okay. That's so interesting. So when estrogen kind of starts, going back to estrogen, starts declining, what's kind of happening to the body from head to toe in a woman? It's hilarious.
It's so fun. You have estrogen receptors in literally every system of your body.
Wow. I actually didn't even know that. Yeah. Really?
Yes. There's some in your heart. There are some in your bones. There's in your gut, in your immune system, in your skin, in your eyeballs, in everything. So when your estrogen starts to decline, you can have global symptoms. So the big ones that get the attention are generally like the hot flashes, the night sweats.
Right.
And that's because temperature regulation, there's some science that goes into that. But ones that people don't really get are your eyesight can change. Like all of a sudden I needed glasses.
Oh my gosh.
My prescription changed dramatically over the course of a year.
Do you think because I'm blind as a bat when I hit
menopause, you're going to need a seeing eye dog.
Yeah. Or it'll fix it all together.
Yep.
I'll be so good.
It's so great. Or joint pain is a common one because you know that, and then osteoporosis because your bones need estrogen to stay strong. So your bones are affected, your heart's affected, your gut is affected, your insulin resistance is affected, your cholesterol is affected, your hair falls out. Like everything in your body has some tie to estrogen, and so when that declines, there can be components of every single system of your body that can be affected.
That just sounds terrible.
Yay!
Oh my gosh, that's actually insane. With estrogen, I feel like a lot of people think of it, I thought of it kind of just as a reproductive hormone. Mm-hmm. So, I mean, you just listed off a million things that it can play part in.
Yep.
What's like the other jobs that it has other than the reproduction part?
So that, I mean, really when you're in your reproductive window, it controls your ovulation, and, makes you be able to get pregnant or have a period or whatever. But again, going back to it's sort of this sort of precursor to a lot of it. There's a lot of downstream effect, right? Mm-hmm. So estrogen is the driver, and then you've got a bunch of other little cars that come off of that. So one of the big ones I see is ADHD popping up in perimenopausal women, right?
Yeah.
And everyone's like, well, this is this new diagnosis, and you don't get ADHD as an adult. Mm-hmm. And what they're not understanding is that most women, and this is a whole other subject, but it's getting missed when they're young, and they're learning coping mechanisms to sort of combat the pitfalls that come with ADHD. Mm-hmm. And then they go into perimenopause. And when their estrogen drops, so does their dopamine, because estrogen is a precursor to dopamine. Mm-hmm. And so that little tiny scrap of dopamine that they've been existing off of for years isn't there anymore, and they can't mask anymore. So then all of a sudden they're like, oh, I'm going crazy. Like, I used to be able to remember to do all these things, and now I can't. And, people will come in and I'll ask them, how are you at remembering appointments? And they're like, I'm great until recently. And I'll say, tell me how you remember appointments. And they'll say, well, I make an appointment, and then I put it in my phone, and then I set an alarm for the day of, but then I also set a reminder for the day before. And then I go home, and I also, if I can remember, I put it on the big calendar in the kitchen so that it's visually there, and then on the day of, I make sure I put a Post-it note on the fridge so I don't forget.
Holy cow.
And then I'll go, you're not good at remembering appointments.
No.
You just figured out a hack in order to do it. And I said, now the hack's not working for you. It's not that you didn't have ADHD, you just figured out how to navigate around it, and now you can't. Mm-hmm. So, but that's a good example of this isn't a new thing, but your estrogen was driving that ability, and now the estrogen is gone, and you don't have the ability anymore. Right.
Wow, that's so crazy. I'm literally gonna pick on my mom a little bit. I told her, I think months ago, that she should go get tested, because genuinely, I do think I probably have an ADHD from my dad. But my mom, recently, I'm like, Mom, you definitely have ADHD, for real. So, that's a great point.
Yeah.
Again, talking about my mom, but...
Your mom's great.
My mom's great. I literally love her. So, lots of women. Yep. Lots of women. Even women that I just know all around me. They often say during that time of their life, they're not recognizing themselves anymore.
Right.
You already hinted at that ADHD. Mm-hmm. Is there anything else happening in the brain that can kind of be making those thoughts happen?
Yeah. So you're losing serotonin too. So I'll have women who are feeling they've got new onset anxiety or new onset depression, insomnia. I've been a great sleeper up till now, and now I'm not sleeping anymore, and I can't figure out why, or sleeping fine, but I'm waking up at 3 a.m., and I can't get back to sleep, and that's not normal for me. And, increased irritability. I'm snapping at my kids, and I haven't. And that one can be tied to a couple of things. But there's a big joke that goes around about perimenopause and menopause where I can't stand the way that my husband chews anymore, and we're going to get divorced because he chews too loud.
Yeah.
And so women are going, it's never bothered me before. Mm-hmm. Why does it now? And there is a level of flexibility that comes from fluctuating hormones, right? We have always existed in our bodies, at least since puberty, in a body that ebbs and flows. There's a lot of dynamics in that. And it gives us the ability to accommodate, right? This sort of like, I'm going up and down and I'm used to moving and going with the flow. And then that ends, right? Mm-hmm. We don't have that sort of ebb and flow of our hormones, and all of a sudden our tolerance, we don't have the ability to accommodate anymore. And that is why you get women who are like, I got no more F's to give. Sorry, I'm not accommodating you anymore. I'm not worrying about you anymore. I'm finally at the point in my life where I can worry about me. And it feels unnatural to a lot of us because we've spent our entire lives caring for people, providing for people, taking care of people, accommodating people. And now it's like, I literally can't accommodate you anymore. I don't have the ability to do it anymore. And we can get really down on ourselves for that because we feel like that's an intrinsic part of who we are.
Right.
But there's also some really great stuff that comes from that too. Like, I don't care what you think about me anymore.
I was going to say it. Like, that also sounds like a positive thing.
Like, I get to live my life in the way I want to live it. Mm-hmm. So there's some benefit. But yeah, there's a lot of women who are like, I don't like this about me. I liked that I
cared.
Yeah.
And now I don't care.
Now I don't care. And what's wrong? And I'm like, nothing's wrong with you.
No.
You just spent a whole life trying to make other people happy, and now you get to work on you.
Which is great. I think more women have to do that.
Yes.
Even before menopause even happens.
Exactly.
So, I mean, okay, so you've already hinted at, like, serotonin and dopamine. Can you also talk a little bit of what cortisol is happening in the body during that time as well?
Yeah. So we often have a rise in cortisol, and that's because, again, that ability for us to sort of flex, we lose that a little bit. And then there's some like chemical systems that are affecting that too. But our stress levels are going up, and usually we have a whole lifetime of not paying attention to that or doing things that help us bring our stress down. And so that cortisol can really build up. And then that also impacts how we gain weight. So we're gaining weight around the middle, and our insulin is a little like off. And the problem is there's not really any way to fix that. Like, there's no pill we can give you. There's no patch that you get to have that can lower that. It's learning how to take care of yourself.
Right.
How to bring down your stress.
How to chill out a little bit.
How to chill out a little bit. How really, honestly, how to take care of yourself. How to prioritize yourself.
Okay.
But yeah, it's not, cortisol isn't something that's directly impacted by menopause necessarily. I mean, there is some component to that. It's more like we're just running into this block in our lives that we're not used to.
Yeah. Speaking of self-care, how do you do that?
I garden.
Yeah? What are you gardening?
Everything.
Yes. Guys, she has the most best garden I've ever seen.
It's it's something that I can do that I can just unplug, right? I will come home and I'll get out of my car and I'll walk outside, take my shoes off, and walk straight into the garden because there's just something about just nurturing and caring and having something produce. Yeah. And I grow flowers, and so it makes me happy.
That is such a
but yeah, so that's probably, I mean, during the summer, and then I like to travel, and so and that's the big thing in this job particularly is you've got to balance that work life.
Oh my gosh, yeah.
Because it's really, really draining if you don't. And so I make sure that I leave work at work. And so that's a big part. Like, that doesn't sound necessarily like self-care, but it is because I don't want to be tied to my job. I cook. I love baking. I read. And again, getting to that point where it's like, I'm going to spend the money on myself. I'm going to go get my nails done. I'm going to go spend them, I'm going to the guy who charges more to cut my hair. And I don't feel guilty about it.
And that's so good.
I just do it.
And you shouldn't.
I shouldn't.
Good
Nobody should.
No, not at all. Speaking of, like, during that stretch during that time, because with psych, it is such a draining job with, like, people just coming in, telling you their problems all the time. Like, that will be draining for anybody, right? And just trying to figure it out. Has there ever been a patient, or even throughout your labor and delivery career, that, like, really stuck with you?
There have been lots.
Yeah.
Lots. But stuck with me in what way? Good way, bad way, just, it's the story?
Maybe a good way. Let's do a good way. Maybe a good way, then a bad way. We'll do both.
Good way, it's the, people coming in and just telling me I've changed their lives. Or labor and delivery. I had, there was a cord prolapse, which is where the cord's coming out before the baby does, and it can be compressed, and then it's really dangerous for the baby. And it's an emergency, and the family was really scared and nervous, and the outcome was great, and they came and saw me on her first birthday, and we're like, she's here because of you, which isn't entirely true, but I'll take it.
Yeah, you're like, absolutely, she is.
Moments like that are really, really satisfying. Frustrating. I had a patient that she'd been seeing me for several months, and just long history of mental health stuff, and just like nothing was working. And we tried everything, and it was really me getting to the point going, I don't know what else to do for you. Like, you've tried every single med, you've tried every single modality, we've tried this combination, we've tried that combination, we've moved to different classes, truly we tried everything, and having to face her and going, what is happening with you goes beyond my ability. And that's hard. It's hard to admit. It's hard to see them, because they've placed a lot of trust and hope in you. And so moments like that are really painful.
Well, I feel like that says more about you as a provider too, of being like, just being honest with not only yourself, but also with her about your capabilities, and being like, we've done everything of my knowledge that we can do for you. So then you're not only not wasting your time, but you're not wasting her time either. So I think that goes a lot further than you think it does. Yes, for sure. Okay, so back to menopause though. That was kind of tangent, but I always love it. I know. Okay, so with menopause, I feel like the biggest, especially when I was your MA, one of the biggest things I heard is like sleep. Sleep is such a huge issue. Why do you think during that time is like such a struggle for them? And why does like getting no sleep seem to make everything worse?
Well, sleep is when your body recharges. Sleep is when your brain can sort things into, okay, this is supposed to be long term, this is short term, this can go in trash. It's when we heal. It's like sleep is vital to us just being alive and human, right? And so when you don't sleep, again, sort of that global impact. I can't think. My body's not healing as fast. My metabolism is slowing down. Like, everything is impacted by sleep. And so protecting sleep is always vital. You will never feel good if you're not sleeping, period.
Right.
It doesn't matter what medication I give you. It doesn't matter what therapy you go to. It doesn't matter. If you are not sleeping, you're always going to feel like trash.
Totally.
And in menopause, along with that decline in estrogen is a decline in progesterone. And progesterone is our calming hormone. So it's what helps us sleep. It's what helps us sort of relax. It's what makes us not anxious. And so when that falls, we get anxious and we can't sleep, and our brain won't turn off, and then we run into this problem of we can't sleep. And there's other, like estrogen also impacts sleep. Your insulin is impacted by menopause, and so sometimes you're going to have like spikes in the middle of the night or crashes in the middle of the night that are going to wake you up. And so there's a lot of things that are impacting that. The biggest one generally is the progesterone. Oftentimes we can see a woman who's struggling, she's in the right age, and we give her a little progesterone and magic, she's sleeping again. Now it doesn't always happen.
Right.
But it happens pretty frequently. So, progesterone is the calming, estrogen is sort of the energizing.
Okay.
Essentially.
Right. What is what's your nighttime routine, or one that you like recommend to people going through that?
It's like, what do I recommend?
Yeah.
Or what do I do?
Let's do a little bit of both.
Okay. I fall into the trap of, do as I say, not as I do.
Yep.
What I recommend is a solid routine before bed. So, biggest one, phone, iPad, TV, off an hour before you want to go to sleep. Blue light tricks our brains into thinking it's daytime. And we inhibit our own melatonin production. So, turn your phone off. And then establish your routine. So, if bedtime is 11 o'clock, at 10 o'clock, phone goes off. From 10 to 10:15, you're going to do some yoga stretches, and from 10:15 to 10:30 you're going to do your skincare routine and brush your teeth and all that. From 10:30 to 10:45 you're going to journal, and then you're going to read for 15 minutes. And if you consistently do that every night, our bodies want routine.
Right.
Our bodies want to know what's happening next, because that is how we feel safe. It is an evolutionary thing. So the more you do that, the more your body's like, oh, yep, phone went off. Oh, yeah, we're doing deep stretches, time to power down. And then adding supplements in is also a good idea. So my bedtime routine is stay on my phone as late as possible, take some supplements, hopefully I fall asleep.
Well, I feel like that's everybody's, though. So that's not even so common.
But I'll also encourage journaling before bed, so that you can sort of empty your brain. If you're waking up at 3 a.m., having a high-protein snack right before you go to sleep can sort of help with some of the insulin issues, so you might sleep through the night. And just sort of employing whatever you need to clear your brain out, to calm your body down, and hopefully engage in some good rest. And there's supplements that I recommend sometimes, but mostly it's that routine.
Right. You've already hinted at diet and exercise a little bit. Why do you think strength training is like so important for the menopause stage?
Because menopause will make you quickly lose muscle mass, and muscle and bone strength are what help you age well.
Right.
So keeping your muscle mass up will also help keep your bone strength up, which means that you're not going to get frail, you're not going to have fractures, you're going to be able to your mobility will stay intact longer. It helps with your metabolism, so the more muscle mass that you have, the more able you are to maintain weight or even lose weight if you want to. So, and the way that you do that is heavy lifting and high protein. And we don't like to hear that. We don't want to hear that we have to actually do stuff.
Yeah.
But it's a huge deal in this age, because again, we don't want to have to age like our moms and our grandmothers did. We have the ability to age in a healthy way, and increasing your muscle mass and keeping your bones strong is going to help you do that. You don't want to be huge contributor to mortality with women are fractures. So if you break your hip, the likelihood that you're going to die within a year is super high. Right? You don't recover from it anymore.
No.
And so preventing that by making sure that your muscles are strong, so that you have good mobility, so that you don't fall, and then making sure your bones are strong so that if you do fall, you're not breaking something, is important.
Exactly.
Yeah.
Isn't it like a crazy percentage of like your bone mass goes down or muscle mass you lose by the age of 30? like goes down like 3% or something every year.
Mm-hmm.
It's crazy to me. So yeah, keep up with that.
Keep up with that.
We've already talked a little bit about hormone therapy.
Mm-hmm.
So, I mean, I guess like before it was a little bit taboo, but I feel like it's been a lot more of a discussion nowadays.
Right.
For sure.
Yep.
Who would you recommend HRT to, and who would you not recommend it to?
Almost everyone I would recommend it to.
Really?
There are very, very, very few cases where hormone replacement is not appropriate.
Okay.
And, well, specific hormone replacement is not appropriate. So if you've had an estrogen-based cancer, breast cancer, uterine cancer, ovarian cancer, anything that is affecting those sex organs, then we're going to be really, really cautious about hormone replacement with you. It doesn't mean you can't have it. It just means we're going to be real careful.
Yeah.
And there are some things like vaginal estrogen that you can still have and are probably pretty vital to your health, is having like vaginal estrogen. And so that would be one category of people that would just a lot of caution, maybe some changes in how we deliver the hormones. There might be some that we don't give estrogen systemically to. Mm-hmm. That's the big category. If you've had a stroke or a blood clot, does not mean you can't have it. It just, again, means we're going to be very, very, very careful about how we do it. So there are 2 forms of estrogen that we use with oral, well, more than 2, but generally there's a pill and there's a patch. The pill, when you swallow it and then it's metabolized, it goes through the liver. And when it does that, it increases our potential to clot. Mm-hmm. So if you've had a stroke, if you've had a blood clot, you had a pulmonary embolism or a blood clot when you were pregnant, we're going to go to transdermal. We're going to put it in a patch because that avoids the liver, and all of a sudden you're not at a clotting risk anymore. But everyone just says you can't have it.
Right.
Which isn't true. And again, we go back to like vaginal estrogen. Absolutely, you can have. That's totally safe.
Right.
So there really are so few contraindications. So few. But you'll have people coming in saying, well, I have a family history of breast cancer. My mom had breast cancer. Or, well, we do have, this clotting thing that happens in my family. And so I've been told I can't have it. Not true. You just need someone who is experienced in hormone replacement to figure out what's appropriate for you and your specific circumstance, but is not going to just be like hormone replacement out of the picture for you.
Right. So like looking at the bigger picture instead of just being like, oh yeah, no, you have this, you can't have it.
Yeah. So there's only a very, very small percentage of women who should not have systemic hormone replacement.
I feel like that also just goes back to the education part of like providers being too scared to prescribe these things because they don't know exactly like what they can have and what they can't. I guess when they see like a blood clot history, they're like, nope, never mind. That's out of the word.
Well, and especially when you're with like gynecologists or OB, birth control pills are kind of lumped into the same category as hormone replacement. And so if you have a history of blood clots, we are not going to give you birth control pills, period.
Right.
But the difference is that birth control pills are synthetic versions of your hormones. So, like, we're not doing progesterone, we're doing progestins. And it's a different type of estrogen. And that type of hormone replacement or hormones, so if you think back to those like receptors, right? Those are locks, and estrogen is the key. And your biological estrogen, that key slides in super smooth, and you can turn the lock, and then everything runs. Bioidentical hormones, so the ones that we're using for hormone replacement, mimic that. So that key, again, slides right there into that keyhole. When we're talking birth control pills, these synthetic versions, the key is mostly in the right shape, and it mostly fits, but we are making it a super strong and powerful key, so it's just going to jam into that lock, right?
Okay. Yeah.
It's going to, like, fill the lock, and it's going to, all the mechanisms are going to be filled with this key, and that's what's going to turn it. Like, it's forcing it in. And so it's much stronger. It's much more potent. It's not identical to what your body produces. And so the risks with birth control are much higher than the risks with hormone replacement. And I'll also have people coming in and saying, well, I didn't do well on birth control pills. Like, I was really moody, or my, whatever. And like, not the same.
Yeah, that is different.
Not the same. So we can still try hormone replacement, and the likelihood is you'll have a much different experience than you did.
Yeah. Wow. I learned so much about menopause today. This is so cool.
All you ever wanted to know.
I know. Can't wait for August when I can learn more. Okay, so I feel like, so you've cared for women through all chapters of their life, like giving birth, going through all these mental health shifts, menopause. After caring for all these women in their different chapters of their lives, what have you noticed that almost every woman struggles with?
Self-care. Self-prioritization.
Okay.
It goes back to that hormone thing of, we are just biologically programmed to take care of people. And we also come from a culture that a woman's value is based on how much she can provide for other people, how accommodating she is, how, like, we hear all the time about these selfless moms who don't eat so that their kids can. And not that is, should be looked down on. That, I mean, what a noble sacrifice, right? But we are glorifying that. We glorify the woman who works herself, and she doesn't sleep because she's up baking cookies for the 4th grade bake sale. Isn't she amazing? Isn't she so wonderful?
Right. And
that message is just shot back. Like, you don't have worth unless you are helping and providing for somebody else.
Yeah.
And then we get busy because we figure the child rearing is supposed to land on us, or whatever. And so it feels selfish, or it feels wrong, or it feels like we don't have time to carve out periods of time for us and take care of us. And that's the problem, is that stupid saying, like, you can't pour from an empty pitcher, which sounds so cliche,
but
is actually true. Right? Like, if you give and give and give and give and give and give and give, you will eventually get to the point where you don't have anything left. You won't be able to give because you have burnt yourself out. And then everyone goes to, well, I don't have time for self-care. Mama, I promise you, you've got 15 minutes a day.
Yes.
Go on a walk by yourself. Go to Target without a list. Lock the bathroom door. Tell your husband he's in charge of the kids so they're not sticking their tiny little fingers under the door. And take a bath with a book, right?
Yes.
It doesn't have to be a spa weekend. It doesn't have to be a shopping spree. It doesn't have to be a massage. Like, it can just be these tiny moments that we carve out where we're not taking care of anyone but ourselves.
Yeah.
And it's not selfish, and it doesn't, like, devalue you. It is essential and vital to you being able to continue on doing what you want to do.
Jeez. Well, I'm like, yeah, it's so true. Amen, sister. Well, to close up this episode, which I feel like we could talk about everything forever, so, especially with us and our personalities, we could just keep chatting. But, so with every woman that's listening, if they could hear one sentence about menopause from you, what would that be?
You are not broken. And this is not the end of your life or your value. It's just a new chapter. And you get to invent yourself, reinvent yourself, whatever you want to do in this chapter of your life. And it can be glorious, and it can be fun, and it can be empowering, as long as you allow it to be.
World's longest sentence.
I just use commas and semicolons.
So many. I love semicolons. So perfect. Nobody it was so perfect. Them. Well, Aimee, you're just a wealth of knowledge. So I feel like I can bring you on to talk about so many other things, which we will do. Sure. We will be doing in the future. But thank you so much. We'll talk to you guys next week.